So this is a discussion of the Agile mission statement. Myself and Dr. Oudkerk will be the moderators, and panelists, we had a few substitutions, but panelists, can you please introduce yourselves to the audience, starting with you, James? Just brief introduction.
Yes, hi, Jim Mulshine. I'm a medical oncologist at Rush University, and I guess I've been with.
Speak into the mic. They're not hearing you.
Okay. Is this one working? Okay, thank you. Jim Mulshine, Rush University, Chicago, Illinois, charter member of I-ELCAP, and charter member of AGILE, and happy to be here. Thank you.
Good morning. I'm Luis Seijo. I'm a pulmonologist at the Clínica Universidad Navarra in Madrid, Spain. I coordinate the Spanish national pilot called Cassandra, and also have been participating in I-ELCAP for more than 20 years.
My name is Jens Vogel-Claussen from Hanover, Germany. I'm a radiologist, and I'm leading a screening trial in northern Germany called the Hanse study. And I'm involved also in the political process implementing lung cancer screening in Germany, which is supposed to start officially next year.
Good morning, everyone. I'm Yiming Wang from Peking Union Medical College Hospital. I'm a radiologist, major in cardiac, CT, and MRI.
Okay, PC Yang from National Taiwan University. I'm a pulmonologist working on lung cancer. I'm involved in the talent study as well as the nationwide low-dose CT screening focused on smoker and non-smokers with family history of lung cancer. I'm also involved in the to develop the Eastern Asian lung cancer screening consensus.
Okay, let's get started. So we're going to be doing audience participation questions here. So if you guys want to make sure you're loaded up, we'll give you a few seconds. 5, 4, 3, 2, 1. Okay. So just as a reminder, the mission statement for Agile is the following. The early detection of lung cancer using thoracic CT has been widely demonstrated in multiple international trials to objectively increase cure rates. Now the international focus is on effective and economical implementation. Increasingly, it is emerging that thoracic CT screening is also detecting a range of early tobacco-related diseases, including cardiovascular disease and chronic obstructive pulmonary disease. These three diseases comprise the big three, as they are collectively account for close to half of the premature deaths globally. Thoracic CT screening presents a unique opportunity to integrate care for this high-risk cohort with a single imaging examination. We plan to develop optimized protocols for evaluation of these major diseases, explore challenges and define solutions in enabling implementation, especially for economically disadvantaged countries across the world. A core strategy in achieving this ambitious goal is to leverage the use of AI processes across the continuum of care, including its use for risk assessment, disease detection, and managing disease interventions. So that's our mission statement. And now we have a question for the audience. What is the most important thing Agile needs to focus on going forward? Educational activities, development of guidance documents, foster and enhance collaborative research between global participants, or provide the rationale for comprehensive screening? Everybody make a choice. And the winner is very interesting. Yeah. Okay, good. So development of guidance documents is the winner. Number 32% is foster and enhance collaborative research, followed by the rationale and educational activities. Well, and I think that's really important, because this is not really meant to be an educational conference so much. But I want to now throw this to the panelists. What would the panelists think of this question. What do you think the important role of Agile might be? Let's hear from each of you, please. Starting at the proximal end and then going distally.
I
Jim,
think,
what do you think? What do you think about these answers, and what do you think personally?
of course, these answers are wonderful, but I think it's good to give emphasis to this developmental guidance. I think we just heard from best practices across the world in our opening session. And I think it's really helpful to have a forum where such information can be shared. Because I think as you get into this, it becomes quite natural as you kind of develop the communications channels to keep bringing forward best practices, to integrate that into documents that then help a broader circle of people be aware of opportunities to improve their performance. It's a big job, and it's a great job.
Luis.
So I voted for number 3, I guess, for rationale for comprehensive screening. I think in Europe, there's a big debate about incidental findings in lung cancer screening and what to do with them, including some nihilists who believe that we're just about lung cancer screening. That should be the focus of everything in screening. I do think we have to integrate smoking cessation into the lot. And I believe as we set up the national pilot in Spain, that smoking cessation, respiratory assessment, so evaluating lung function and cardiovascular disease has to be the focus. And I think Agile should focus on that comprehensive screening rather than just this nihilistic approach to, simplistic approach to screening as just lung cancer centric.
Good.
Yeah, I think number 1 is the development of guidance documents. I think this is what we need, and it goes with number 2, the research, because the guidance needs to be evidence-based, right? I think we can check the box in lung cancer screening. We have enough evidence to implement programs, but in many countries, we cannot check the box on all of the big 3. And the mission is that we provide guidance and to foster future collaborative research to make those checkboxes in the future for all the big 3.
Okay, next.
Okay, thank you. I think the first, I'm sorry,
She's not.
the first.
You have to speak closer to the microphone. It's not
Okay.
coming across loud
I
enough.
think the most important thing is to develop the guidelines for everyone, how to screening the lung cancer and how to screening the coronary artery disease. But we also need to foster and enhance the collaborative research between global participants to provide our own evidence for the guidelines. Thank you.
Yeah, I also concur with that the development guidance is most important. Actually, if you compare the lung cancer screening with breast cancer screening, you see that the lung cancer screening is too conservative, and especially not only on screening, but also on the management or treatment. I think we need to look to the future, especially we want LOCD screening to cover big 3. We need to provide evidence. It's not possible to develop a randomized trial cost effectiveness for this kind of big 3, especially for cardiovascular disease or pulmonary emphysema. But it's possible that use AI to generate pseudo control that you can try to estimate the cost effectiveness and provide a guideline for the future.
Now, remember, this question was meant to be what this conference can do. And so, this is a small startup, so to speak. And so it's really interesting, these answers. I mean, I think we have a big dream for ourselves. And I'm going to take my privilege as the first moderator to ask Matthias what he thinks the right answer for this would have been.
Now, I think the most interesting thing is that the educational activities have no emphasis at all.
Right.
So we had internally a big discussion if we should do this, so we have an answer. And I think we should really regard it as the 3 outcomes almost equal. So I think we should stress on all the three. And there is the comparison that is made with breast cancer is very interesting because breast cancer screening is really one organ approach. And we have a multi-organ approach, and that is why it's so complex. So I would say I think it's a very, very nice feedback from the audience. So this is
Okay,
also
okay.
my side.
This is, yeah, okay. Which of these technical processes should Agile focus on going forward? Develop AI validation procedures, develop globally acceptable quality assurance and monitoring processes for B3 early detection, or enhance multidisciplinary integration, including liquid biomarker research. Really interesting. Okay. Shall we start in the same direction or go the opposite direction? Start the opposite direction? Okay, we're starting distally and going proximally. Professor,
Okay,
Wang.
personally, I choose AI. I do think that we need AI to assist, to help us to certify the nodule detected by low-dose CT, the risk and the sensitivity and the specificity, and then we are able to more precisely screen the lung cancer and also big three by low-dose CT.
I personally choose AI because I think the AI developing speed is beyond our thought. In other areas, like the information or some other industry is developing very fast. I think it will influence the medical treatment therapy. So I think we need to do something about AI. Thank you.
Yeah, I personally also voted for AI, but I think I struggled between the quality control and AI. I think we know for a fact that we get influenced by AI through everyday reading. In Germany, it's in the law that you have to use a suitable software. They don't say AI, but we replace for the screening measure in Germany in the future and now actually the second reading by AI. And we know in the Hanse study, we did that, and we know the readers got influenced by AI. So we need to acknowledge that. And we know that bad AI or less performing AI is pulling down the radiologist's performance. The second is the quality assurance. I mean, we all know that there's heterogeneity between performance in centers. And if you do not have quality assurance on the positive predictive value, for example, of your invasive procedures, you never know. You all think you're great, but you need to score each other in perspective with the other centers and learn from each other. And I think this could be a good platform to foster this. Thank you.
So I voted for quality assurance, although I could argue that AI validation and quality assurance are one and the same. So there's an element there of agreement in terms of what the mission for Agile should be. And as you know, I'm a big proponent of accreditation. I think we are an international effort that could focus on accreditation as a means to assure quality in screening worldwide.
Professor Molshine.
Yes. So much like Luis, I think AI and quality assurance are the two faces of Janus. How are you going to get, validation if you don't have criteria for performance that reflect what gets the job done or not. So I think they're the same thing. I think it's a great challenge for Agile to focus on. And I must disagree with the idea that this group is just a little, rump activity. This group controls more images of chest imaging than any other group that you could constitute in the world. And right now, the gold of AI is the ground truth embedded in clinical trials and ongoing cohort studies of screening. And to the extent that we are advocates for people in terms of how those tools are developed to ensure that they're equitable and distributed and affordable and all those other things, we have enormous power collectively. So I think that's very important. The one other thing I would say is when many of us were younger, we were very excited about the development of electronic health records. Because, how could it hurt that you have all this information at your fingertips and this, that, and the other thing? And then EHRs were largely developed not by care providers. They're developed by the financial concerns of various healthcare delivery systems. And as a result, we spend billions of dollars and we wind up something that pushes us farther away from our primary mission of interacting with patients. If we leave AI development to somebody else out there, we run the risk of having that same challenge thwart what could be an incredibly important public health and a profound benefit to all of our shared societies.
So Dr. Mulshine, you agree then with my opening introductory remarks that Agile is now the preeminent conference and we should start flexing our muscles? Is that basically what you're saying?
Yeah, I used a Ouija board.
Okay, we had one more question here and then we'll go to. Oh, do you want to comment?
No,
So,
I think one thing is underestimated. I think indeed both are totally interdependent. So the quality assurance and the AI validation are more or less cannot go without each other. So there is no way to separate it. So that we all agree on, I think. And then we have the other thing, the integration of the liquid biomarkers and all that compass. There's an enormous effort in terms of money-wise spoken. I think we should get them in to control it. So that should be understood, that it is important that all those efforts that want to replace everything we do by just one test, we all know that we can go through a length of procedures to prove that it is not working, but it is better to get them in and let them indeed also make the same, provide the same evidence as we had to do in 20 years. So I think it's important also not to underestimate that integration.
yeah, the whole purpose of the session 8 on biomarkers is, I think, to really address that question, that the level of evidence really needs to be high quality. We can't let them slide in. And I also just want to say I agree with the idea of the quality assurance and the AI. And they're not the same, but they're dependent on each other is the way I view it. And you, as you saw, I think the audience had trouble sort of deciding which one. So here's the next question. This is a little tricky, this one, but I think I'll explain it as I read it. Which role is most suitable for Agile in regard to helping countries set up screening programs? So the first is we should maybe develop a consensus statement or protocol document so as to maximize standardize use by participating countries. In other words, find something that is kind of the same for everybody. Everybody collects the same exact data. It's really, there's not much fair. The protocol is the same. It's uniform so that we can really compare apples to apples. That's one option. The second option is, no, we don't make everything the same. We sort of make a little bit of a template, and then each country decides what elements, to put in for each of the criteria. They may say 6 months follow-up instead of 3 months follow-up, but there's differences in some of the criteria. The third is rather than let the countries decide it, let's just, us as a group, say we pick a team of experts here that have a lot of experience in developing protocols, and each country comes and presents their, what their country, some features and facts about the country, and the team of experts helps build a protocol and presents it to them. And the final one is that we act only as a platform for comparison. We don't do anything with developing protocols. Rather, every country develops their own protocol, and we act as a facilitator for contrast and compare. So those are the 4 options, going from the most rigid to the least rigid. And where do you think we sort of fit in? We good? Good. That's a really interesting answer. There's clearly a winner here. And that is that basically we identify the main critical elements and the countries decide, what to do, so that there's sort of a template, but that each element has variability and the country decides how they want to vary these various criteria. Start on proximal again.
Okay, well, thanks. These are great questions, and I think this is a great
Thank you,
example
Tim.
of how Agile can work. And I just want to point out that there's 5 or 6 times as many people on the Zoom as are here, and I want to make sure that we get that feedback into these conversations as well. But David, I think that I agree with the conclusion that came to from the vote. I think the concept of standardization is kind of scary. I think the concept of harmonization, so you kind of have the same targets, but you allow a certain amount of flexibility in terms of how they're achieved, and there's discussion about that intentionally with respect to allow progress. So I think this is a very interesting issue, and I hope we're going to come back to this in the course of this meeting.
Dr. Seijo, what do you think about this?
It's a tricky situation because I think tutelage is controversial and problematic. If you try to guide people, certainly countries and policy making, you're going to meet a lot of resistance at the local level. So I would not be in favor of tutelage. I'd be in favor of guidance and probably more so quality assurance. So keeping the element of guidance by assuring quality and implementation rather than by telling people what they're supposed to do. So I'm in favor of acting as a platform. And when you say act only as a platform, almost sounds like you're restricting yourself, but acting as a platform for comparison and critique, I think, and guidance would be a role.
Yeah, I think we live in a heterogeneous world with heterogeneous healthcare systems and payers. Just picking up on you, Matthias, you said, oh, there's a process of your government looking into lung cancer screening. The same process is in Germany. We're in Europe together, but the governing bodies are still the countries. And so we together with the policymakers, we need to make the rules. And this is setting the framework. So we live in the country's healthcare systems and need to find a common way to get to lung cancer screening. And this is why it identify the necessary critical elements to empower countries. I think this is it, empower countries, because we want to reach a common goal, right? Reduce the all-cause mortality in lung cancer and holistic screening. Yeah.
Okay, I choose the second secondly, because I think it is easier to provide the basic template, because each country has their own situation and problems. So AGILE can help them to make the guidelines more perfect and more suitable for their own countries. Thank you.
I also endorse the second option. I think that in different region, the epidemiology lung cancer may be different, and also the resources, healthcare system, as well as the availability of the CT scan. So individualize each region and the practice the so-called precision screening would be most suitable for AGILE to promote lung cancer screening or big three screening.
Can I may add something, because we spoke on the empowerment of
Yeah.
each individual country,
Go.
but I think we at that stage now this is what happens now. But I think when we implemented lung cancer screening programs, and we think and see one program is performing better than the other, there's a next phase where we learn from each other, and then the programs will be more harmonized in the future. That's my vision. Yeah.
Do we have anybody? Did they finish? Did Pan Shir do his? Did Yang? Did you finish? Everybody finished. Matthias, did you want to add anything to this or no? Not
No,
forcing.
No. But very briefly, I think it's a clear answer, but it is amazing that. Sorry?
No,
Oh.
pointed to. Go on.
No, it's amazing that the third is really not that highly evaluated. We could indeed also, I think, if we need key experts, especially for things that influence the measurements of everything we do in the data acquisition, I think that could be a way also to enhance what we are doing. So,
Dr. Henschke, I think that, okay. Dr. Henschke, we're gonna ask you to comment on this. What do you think about this question? How would you have answered this? Yeah. That's why we did it.
I chose number 2 because I think for exactly the reasons that have already been stated, you want to leave more flexibility, and as solutions emerge, or whether they're AI or procedures or how to retain people like Steve Markowitz showed with his, I want to see how he retained such a high retention rate. So all of those things we can learn, and then we can make more definitive statements.
Yeah, I think I also would have chosen number 2 because I think it's very hard to tell countries that, you know, where you don't know their challenges, their resources. Not every country can afford to work up every 3 millimeter nodule or 4 millimeter nodule. They may want to set their thresholds a little higher. And I think you have to go with what their priorities are. Some countries prefer to lower false positive rates. Some countries prefer to find every single cancer. You know, different resources. And I think number 2 gives you the most flexibility, that they understand their own quality assurance has to be standardized. Well, this gives you sort of a template that you follow. Everybody still is on the same sort of basic template, and you can follow the same sort of quality assurance. Okay, those were the only questions we had for audience participation. Do you want to now take the lead on the written questions we had?
now there are many issues that are already, I think, addressed in the discussion so far. But I think there is one question that would be very interesting also to address now. And that could be also one of the voting questions. What are the major manpower shortages? That's different also per country. So I would like to start here, not vice versa, but with Jim Mulshine. That's for the major manpower shortages.
Yeah, so there was a choice. There was radiologists, coordinators. How does AI impact this?
Boy, I think that's a hard one because I think they're all, I mean, we're at, in the United States, let's say for sake of discussion, we're at 20% implementation of target population. And many of the institutions that are, you know, big screening centers and stuff like that, they think they were maxed out a couple of years ago. So as we move from 20% to, 80%, the manpower, the person power, medical professionals are going to be needed across the board. And whatever one you don't pick is going to be the one that is the weakest link that the process collapses on. So I don't know how you make that decision.
So as we ask these questions, if for the panelists, if you have something you really want to say, if you feel that it's already been answered to your side, you don't have to comment. So the remaining panelists, do you want to add to this, in particular, the manpower issue? You know, I can tell you just from my point of view, the radiologists, a lot of countries, it's the radiologist is now the big manpower issue. So please.
Yeah, I think that's the obvious issue, the radiologist, but something that's underappreciated is the coordinator. And this is a key element in a screening program that I think we just undervalue. And there's no money for it. And because that person has to be usually a nurse coordinator, it's just not financed and nobody pays attention to it, but it's the glue that keeps the program alive and working properly in terms of reaching out to the patients, making sure people have to come back when they get screened. If they're worried, who they contact, that contact person is key because of all these issues of incidental findings and additional findings from the screening that make people worried. And I think we underappreciate and undervalue that and underfinance that.
Yeah, I think AI helps you to be more confident in making your diagnosis. I not necessarily think it shortens the workload of the radiologist, because what we see, what is possible, all in analyzing for free, but someone has to look at it, right? It has to look at the calcium score, has to look at the emphysema score, make a recommendation. In the Hansa study, we knew this, and I had only a certain budget, and we streamlined it. We had predefined texts for calcium score, which was positive. We had a predefined text about emphysema score above 6%, and the letters were automatically sent to the GP and the participant themselves. So automatization, streamlining of text, and only reporting clinically relevant findings in the free text section, which are demanding a biopsy or a surgery or a imaging or a follow-up. We don't report necessarily findings which are just there to be reported and maybe make the person nervous because they're healthy. They just smoke or have a family history of lung cancer. And they may be concerned about their gallstones they had for many, many years. So I think putting it in perspective, having more CTs, but being more organized with AI to structure clinically relevant reports.
You're good? You want to say anything, add, or you're okay? Did you want to add anything? No. Okay. Do you want another question?
Okay.
Or
Because-
burden, workload.
Because I'm doing cardiac, so I think AI helps the coronary CT a lot. Usually we use 15 to 30 minutes to do the post-processing of the coronary artery segmentation and stenosis analysis. But now we can use AI. It only takes 7 minutes from the scan to report. So I think regarding the cardiac CTA, it's useful. And in our hospital, we have around about 30 coronary CT scans per day, and more than 90% we use AI to do the post-processing. Okay, thank you.
I think that shortage of manpower is very significant factors or hurdles to to implement those CT screening. Especially, we want to extend from lung cancer screening to big three. The shortage of manpower would be very serious. Actually, we implement those CT screening nationwide, those CT screening, and then we found that the radiologists, the shortage of manpower is very severe, and many so we try to aid the AI to assist the report, and also the to give the incentives for the radiologist to speed up the report. But if we want to extend to big three, that would be a very significant problem.
Do you want to add anything? Yeah, I agree. AI is an interesting, we like thinking of it as shortening the reading time, but it doesn't really.
It's
It
the way
shows
you
you
apply
more
it.
things and you have to evaluate a lot of things it finds. To dismiss it becomes a little harder. Everybody gets nervous about saying, well, I disagree what it found. Because you're just thinking, well, it showed something. What if it was correct? Now I'm saying it's incorrect. So there's a lot of different aspects there. Go ahead.
Nou ja, I will address it later on, but it's the way you apply it. So I think AI will play a major role, but in a different way than we can foresee now. Shall we go to the next question then?
Can I just make two quick comments about this? One is we did not specify that tobacco control, smoking cessation experts and stuff like that is part of this team. And it's got to be. And there's no one here to defend that skill set that I know of. But if we don't have that, we're missing an enormous public health opportunity. And they are oversubscribed and under-resourced, as discussed already. And the second thing real quick is the future state of the big three, which I'm totally supportive of, is that that person walks out of that screening evaluation with a 50-page beautiful AI printout. And they're left to go home to whatever the resources are at home to deconvolute that hieroglyphics.
Sure.
It's a real challenge that we're going to have to stay aware of. And AI readouts are not necessarily empathic.
No, per definition, they are non-empathic.
You can ask them to be empathic.
Yeah. Shall we go to the next question? then?
Yes, please.
Yeah, I think a very interesting question is how you appreciate the combination of the three. So should we compare that to lung cancer screening alone? So how far should we focus on the combination of the big three and if you compare to lung cancer screening alone, and how do you evaluate the future? So can we start with you at the end, Dr. Yang?
How to implement the big three? Is that the question?
No, yeah, everyone focused till lung cancer screening alone. Now the other diseases, the comorbidities are coming along.
Yes.
So cardiovascular and COPD and emphysema.
Yes.
So, how do we appreciate it? Should we integrate that also here, or should we first focus on lung cancer screening alone? That's the question.
So far, I think that we should focus on lung cancer first, and then we want to expand to big three. Maybe we need to provide to the public also to the we need to provide evidence to support the cost effectiveness that we screen big three, we can reduce the cardiovascular mortality and COPD mortality. It's not easy, as I mentioned earlier, not easy to develop a randomized trial for this kind of the big three screening. So, but compared to the use the general population pseudo control, probably you can answer that. If we have good evidence, then we can promote the big three screening.
From my point of view, I think within the insurance coverage, we can put focus on the lung cancer screening. But for some private, I think like the screening center, they pay by themselves. We can promote the big three, because in China the insurance I think that they cut short the insurance coverage and the money. So maybe we cannot to promote the big three more. I think because we are less of money.
Yeah, looking at the big three together or separately. I mean, from a scientific point, what you said, we need the evidence. So we need to look at them separately and then maybe combined to have an overall cause mortality reduction. This is our aim, right? That the overall mortality is reduced. So scientifically, I think you have to move separately, then jointly on the combined effect of the two coronary screening and COPD, and then the big three together. Reducing, and I think we have a very good chance in reducing all-cause mortality if we do that, but there is no evidence. And the question I would like to put out there: are we for coronary? Are we really detecting it early? If there's a 75-year-old participant or a 70-year-old participant, isn't it too late to reduce the cardiovascular mortality? The answer is probably it's never too late, but the effect is smaller, right? So we need to tease that out. We need to provide the evidence. And in Germany, I have to say there's a big push, especially in Germany and the Western world. We're in the aging population. We live with those comorbidities, and there's a big push for early detection and prevention. I think we're in the area of this, and I think the big three fit in pretty well.
So to me, there's a major challenge with the idea that we combine lung cancer and emphysema and cardiac disease detection, because lung cancer is about your negative predictive value in terms of when I go and get a scan and I want to know if I have lung cancer, so I want to rule it out. Whereas if I'm healthy and I'm a participant in a screening program, if I have emphysema, I don't necessarily want to know that I have emphysema. I want to know if I have clinically relevant emphysema, and same with cardiac disease. So there, it's really about the positive predictive value of the scan. Is this scan telling me that I have clinically relevant emphysema or clinically relevant cardiac disease that I need to do something about? Because I don't need to worry about the fact that I have, a little bit of emphysema or a little bit of coronary calcifications, but I do want to worry if I have a little bit of lung cancer, right? So they're very different in terms of what we're asking the test to do for one and the other, and to combine the three, that's to me the big challenge. The focus is different for cancer than for the other two.
Okay.
So I listened to Claudia's presentation this morning of 25-year outcomes, and I was amazed at the fact that if you follow this as they have with the largest experience in screening to date, that the people that come into screening, the predominant cause of death is cardiovascular disease, followed by emphysema, COPD, and then there's lung cancer. So, if I'm just looking this at the first time, I'm asking, why are you calling this lung cancer screening? Because it's not where the action is in terms of public health benefit. And I think we need to step back and say, okay, if someone is coming for the first screen at age 45 or age 50, wherever it's going to be, and we're starting to talk about these kinds of data that Claudia's already generated that mirror exactly the epidemiological data that came out of the NHLBI 30 years ago when they looked at the epidemiology of tobacco-related diseases. And they mirror what they found out when they did the first presidential report, Surgeon General's report in 1963, in terms of tobacco-related disease. If we call this tobacco-related disease and didn't get into the organ-specific stuff of this, it would all make sense to most everybody. We don't call mercury toxicity of this, organ versus that organ different diseases. It's a consequence of exposure to mercury. This is all a consequence of a chronic exposure to tobacco, plus lots of other things, as we heard this morning. But Tom Petty in 2004 in an editorial in Chess said, lung cancer and emphysema are the same disease. I think we need to just start thinking about this more fluidly from a public benefit perspective.
By the way, I just want to change just very, very briefly. I was told that we have several high school students that have joined us today. Are you in the room? We have them here. Wonderful. I'm really delighted that you came, and whoever encouraged you to come, I want to congratulate you. This is really wonderful to see younger folks getting interested in this. I hope you enjoy the meeting. and you'll come and say hello to us so we can continue to encourage you. So wonderful. Another question that I have, and this is something, again, with the view of what Agile's mission is. Claudia has been involved in setting up screening programs in really low income countries where they're very resource limited, especially even in the number of CT scans. And it's kind of dawned on us that, that the majority of the cancers are not going to be found at lung cancer with CT screening. They have all of these chest X-ray clinics where they're screening for tuberculosis. And when they find lung nodules, they're ignoring them because they don't have a lung nodule program. They don't have an incidental nodule program. Should Agile be in the business of early lung cancer detection, meaning the comprehensive view of things, get involved in incidental nodules, get involved with the TB screening programs to make sure that they follow up on nodules found in screening? So all of these are important and we understand it, but should this be the business of what Agile is doing, or should we continue to stay focused on screening for the big three? What's our mission? Are we an early diagnosis group? So, in other words, we all understand that that's important. And if you're going to do early detection in low income countries, you'd have to do those things. But should that be our mission in Agile? Should we get involved in that? Any takers on this? I can throw it to you, Claudia. What do you think? There you go. Go ahead.
I think an incidental pulmonary nodule is very similar to a nodule detected in screening because it's part of the human body, right? It's I think we have a big problem because most of the countries are doing risk-based screening, right? So we exclude the majority of people who do not smoke. And we have that, but CTs are more done over the world and we detect those incidental pulmonary nodules. In fact, there are many studies in the United States, they make out a bigger portion even of the detected nodules. And my vision, and I think maybe it's the Agile's vision too, could be that we combining, right, the incidental pulmonary nodules and the screening detected nodules in a common trunk workup, right? Where is the reason for following them differently or slightly differently and having two parallel systems, joining them into one would be, I think, something we could recommend and maybe write a paper about. Or
that's actually one of the papers at the end. Exactly. That's one of the exact papers that we're going to be talking about. They shouldn't be different. Professor Mulshine.
So I think boiling the ocean has a certain charm, but it also lends itself to a predictable outcome. And to the extent that Agile has one of the most audacious mandates that you'd want to, and just, bringing together this awareness and capability and accessibility to screening these tobacco-related diseases, I think focus is critical. And I think that to the extent that we can optimize and improve on economic efficiencies and stuff like that, we can make this service available in the third world or the developing world, the low cost and middle income countries. And I've been told that by many people that do screening in Brazil and other places. And I think it's laudable that we do a lot of great things, but what do you really want to affect? And I think the corresponding focus is critical because what we're asking you to do is unbelievably ambitious.
As one of our late mentors, Oli Miettinen, used to say to us, focus, focus, focus. So anyway, we are out of time. This was a terrific discussion. Thank you so much to the panelists, my co-moderator, and we'll get on to the next session.